that I get the, someone has raised hand. Why has someone raised hand? Yes. You want to say something? Someone raised a hand. Hello. By accident or you raised a hand to say something?
Yes, I saw it. It was an accident.
Right, okay. So even that say soon, otherwise we are wasting time. Right. This lecture is basically a clinical sciences stream lecture, right? Most of the lecture you notice that in the neurology module are clinical lectures. That is because you realize in this curriculum there is no other opportunity of teaching you clinical sciences. And these are never taught again. You are expected to learn this here and apply it in your clinicals. When you come to the professorial, we won't be teaching you again these topics because you are assumed to have learned all this. When you come for the final year, you have learned everything that we have taught you here. So there won't be any repetition of this teaching, and this is all you get. So this is a culmination, this is a marriage. Today's topic is a marriage between the pathology and the clinicals and the neuroanatomy. And it is very relevant to the exam that you get at the exam end of the course, which is the short cases in medicine, which is short cases in neurology. Okay, so let's start. Now I told you a neurological diagnosis has two components. What are these two components?
What is the lesion and what is the lesion?
Good. So you just have to answer two questions. Where is the lesion? What is the lesion? Right? So even at the exam, now I keep repeating this to you because in the exam you have to think in those lines. Otherwise your answer will be incomplete, which will be to your disadvantage because you will get only half of the mark if you answer half of the question. Unlike, you know, before the neurology module, now you are at the end of the neurology module, you have the required knowledge to answer both questions. Now I do this lecture for the first years. Now they can only answer the first question because they have done only anatomy. Whereas you now have learned all the different pathologies also. So you should be able to answer both questions. So that is what we are doing in this lecture, bringing all together and see how you can apply it into day-to-day clinical practice. So what does where is the lesion mean? The question is where is the neuroanatomical localization, right? And what is the lesion is the cause or the etiology. Understood? Now this is a common instruction that you get at the final MBBS short case. Examine the eyes neurological. And in the short case at the final MBBS you get only 5 minutes with the patient and 2.5 minutes to discuss with the two examiners what you have found. So when you get an instruction, you must come prepared because you can't come to the exam and think, what am I going to do next? What is expected of me? So this is something you practice. So there are several components when you say examine the eyes neurologically, we expect that you have done these following steps. One is inspection. Secondly, excuse me, visual acuity. Color vision we do not bother in the short case. But in usual practice, it's good practice to ask the patient, showing him a red object, green object, blue object, and ask the patient, can you see these colors? Thirdly, visual field. So you should know how to evaluate or measure the visual fields. Fourthly, eye movements. And we go in this order: inspection, visual acuity, visual fields, eye movements. Next, the pupils. Now, very important to look at the size of the pupils, reaction to light, and accommodation. And finally, fundoscopy. There are ophthalmoscopes by the side of the patient. So you are expected to look at the fundus, and in some patients there will be abnormalities. So you need to develop the skill of looking at the fundus. So I'm giving you this warning upfront so that you will be able to improve your skills. Of course, during the pandemic of COVID, we do not expect students to do ophthalmoscopy. But by the time you come for your finals, I'm sure the pandemic will be over and you'll get back to normal life. Now, what I'm going to emphasize in the rest of this lecture or impress upon you is the power of inspection, right? It's a very powerful tool, this inspection, which I would rather call observation rather than inspection, because you learn a lot. All right. So let's go through this. Now, what abnormality do you see in this picture? Anyone?
Right. Eye is slightly deviated to the lateral aspect.
Good. Right.
And then a slight ptosis on the same eye.
On the right. Right.
Yes.
Anyone disagree? Any other abnormality anyone has noted?
Pupil size is reduced
Which side?
in the right side.
Yeah. Now in neurology, it is absolutely important. I keep repeating that you must always mention the site. At the exam, if you do not tell the site, you don't get marks, right? So that is what we call lateralization. Lateralization is a big word, but all it means is saying left or right. So you feel that the pupil size is small on the right side. Okay. So this is, how did you come to this conclusion? What means did you use? What examination technique did you use? Simple observation or inspection. So your first step. So you can see on the inspection, you have observed that the right eye is deviated to the right or laterally, and there is partial drooping of the right eyelid. Agree? If anyone disagree or do not see these things, please ask, because the whole purpose is for you to learn, right? It's all right if you can't see now, you will see later once it's pointed out. So you need to learn. This is a learning process. Some people know, some people don't know. That is all right. Right? This is all a learning curve. So what do we observe? A unilateral partial ptosis on the right side. Now, the minute you see that, your mind, the knowledge you have to work out where the pathology, where is the lesion. So the first question is, where is the lesion? Before we get on to the second question, you cannot answer the second question without answering the first question. Right. So if there is partial ptosis, then you have to ask yourself which muscles elevate the eyelid. So there you have the cartoon of the muscles elevating the eyelid. Which are the muscles? The main muscle is levator palpebris superioris, which is innervated by the third cranial nerve. There is also the Muller's muscle, which is innervated by the sympathetic fiber. So when you see a patient with partial ptosis, you know that the problem can be either levator palpebris, which is innervated by the third nerve, or it could be in the Muller's muscle, which is innervated by the sympathetic. Already you have two possibilities where the lesion is, either in the third nerve pathway or in the sympathetic pathway. Okay. Right. So that brings us to our first poll. You have the observation. Right. Right. Mm-hmm. Okay, you have 1 minute. You can see the picture. Move the thing away and get it. There's a single answer. "30 seconds more." 15 seconds more. 5 seconds more. So we will stop there in full. Share results. Right, so 65% have gone for right Horner syndrome, 10% for left oculomotor nerve paralysis, and 20% for right oculomotor nerve paralysis. Okay. Right. So how do we differentiate? So what do we notice here? There is this. What we notice was it? Anyone?
Ptosis of the right eyelid, partial ptosis of the right eyelid, and meiosis of the right same eye.
Same. Right. So what are the possibilities when you see this eye? You see a right-sided partial ptosis. So when you see a right-sided partial ptosis, what are the possibilities? So already I told you, it could be a Horner syndrome. I already told you it could be a third nerve paralysis because the Muller's muscle, on the Muller's muscle, the levator muscle is innervated by the third nerve. Now, if it was a complete third nerve, there will be complete ptosis. So in your answer, because it's a partial ptosis, you must always say partial third nerve ptosis. What other two possibilities would cause right-sided partial ptosis? Anyone else?
Myasthenia gravis.
Very good, excellent. Anything else? One other thing?
Horner syndrome.
Congenital ptosis. Horner syndrome we have already written down. You can see my slides, yes?
Yes, sir.
Right. So how do we differentiate now? You see, we started off by this inspection, where we saw this partial drooping of the eyelid. So just by inspection. And then we came to the assumption that it is either a weakness of the Muller muscle or the levator. Then we know the Muller muscle is supplied by the sympathetic nerve, the levator muscle by the oculomotor nerve. Right? And then based on that, we come to these 4 differential diagnoses. I told you in the myasthenia lecture, asymmetrical ptosis is myasthenia gravis until proven otherwise. So you remember that. That's very good. That's a neuromuscular junction problem. And congenital ptosis is some people are born with a partial ptosis. It never progresses. It never gets worse. It never gets better. It just remains a partial ptosis. So how do we differentiate between these conditions? The key is the pupil. So that is why it's so important. If you remember in those steps that I told you in examining the eyes neurologically, one of the steps is looking at the pupil. Now in Horner syndrome, the pupil is small. In a third nerve palsy, the pupil is either normal or dilated. It is never small in a third nerve. In myasthenia gravis, I told you the pupils are never affected. Congenital ptosis only relates to the eyelid. It has nothing to do with the eye. So the pupil is normal. Now, in this patient, what is the diagnosis?
Right-sided Horner syndrome.
Do everybody agree? Yes or no?
Yes, sir. Yes, sir.
Right. So all this have been, we have come this far simply by what? By inspection. Okay. So now we have got a diagnosis simply by inspection. We have a right-sided Horner syndrome. And we have differentiated it by, now at the exam you will be asked for a differential diagnosis. So on the differential diagnosis you say it could be partial third nerve, myasthenia gravis, congenital ptosis, but because the pupil is small, It can only be Horner syndrome. Now, the next question is saying Horner syndrome good enough for localization? No, it is not good enough because you need to further localize. So that is where you need your anatomy on the sympathetic pathway. So you know that the sympathetic system starts in the hypothalamus and the fibers, the tract passes through the brainstem. From the hypothalamus, the midbrain, pons, medulla, comes through the spinal cord to the superior cervical ganglia, and then it ascends. And then the sympathetic fibers passes across the internal carotid arteries into the pupil. Okay. So this pathway is important because now here is a patient with Horner syndrome. The lesion can be anywhere in this pathway. So that is why you learn the anatomy of the sympathetic path. Because all you see in the patient is a partial drooping of the eyelid and a small pupil. The rest is for you to localize. So if you look at this, the lesion can be in the medulla, which is a lateral medullary syndrome, like a stroke, posterior inferior cerebral artery infarct. Could be a glioma in the brainstem. Or it could be like we learned multiple sclerosis. You can have a demyelinating plaque in the brainstem. The lesion could be where the nerve is coming out into the superior cervical ganglia, through the first. Here you get the cervical ribs also. Now within the spinal cord you have the lesion of a syringomyelia or intramedullary tumor. As the nerve fibers come out, a cervical rib or a Pancoast tumor. What is a Pancoast tumor? It is an apical lung carcinoma that can infiltrate into the lower cords of the brachial plexus, including teeth. The lesion could be in the carotid when the fibers are going through the carotid artery, where you get a carotid dissection or a carotid aneurysm. Okay. So how do you localize to each one of these things? So that is where you use your clinical skills. Because you know if the lesion is in the medulla, you get other clinical features. So go and read up what are the clinical features you will get in the lateral medullary syndrome. Right? And you will expect to see upper motor neuron signs because the central nervous system is involved. Here in syringomyelia, I have taught you in the cord lesions in syringomyelia, you have wasting of the small muscles of the hand. You loss of temperature in the hands. These are features of syringomyelia. In a cervical rib, you will have again C8T1 wasting and weakness in the hands. Right? So that is why in patients with lung carcinoma, we always look for a Horner syndrome. We look for wasting in the small muscles of the hand. Similarly, when we see small wasting of the small muscles of the hand, we look for a Horner syndrome. If we find a Horner syndrome, we do a chest X-ray because we know it can be an apical lung carcinoma. And carotid dissection, whether there's neck pain. So that's how you localize the lesion further. Right. So that is for a Horner syndrome. What is the abnormality that you see here?
Partial ptosis on the left eye.
Right. What are the possibilities here?
Left-sided oculomotor, partial oculomotor nerve palsy, and left-sided Horner syndrome. And
okay. Anything else?
Myasthenia gravis and congenital ptosis.
Yeah. All four will come into play. But here, what I'm trying to teach you something additional. Now, this can never be Horner syndrome. Can someone tell me why?
Because in the Horner syndrome, the muscle is affected is the molar muscle, and in oculomotor palsy, the muscle which affects is the levator palpebral superioris, which is more powerful than the molar muscle. So molar muscle never can cause more ptosis in the eye because it is not that strong. And in this picture, there is much more ptosis than
Hello.
there is in this picture the ptosis is much more than we can when there is a palsy in the when there is a Horner syndrome. So this shouldn't be Horner syndrome.
The Anuradhini.
Yes.
Yeah, that's excellent. That is absolutely correct. What you said was absolutely correct, because the Muller muscle can only elevate the eyelid a few degrees. The major work of elevating the eyelid is the levator palpebris superior. So for you to see Horner syndrome, you have to strain your eyes. You can't see it easily. It is very, very subtle, like you saw in the previous picture. Okay. Whereas here, if you see obvious ptosis, it cannot be Horner syndrome. So in your differential diagnosis, Horner syndrome doesn't come in. So it is a third nerve oculomotor nerve palsy. Okay. So Horner syndrome doesn't come into the picture. So again, by inspection, you're just looking at it and knowing what just was mentioned is that the partial ptosis in Horner syndrome is very subtle, very mild, that you have to really, really struggle to see it. Whereas here, this is very obvious. So we have a left-sided oculomotor nerve palsy, again purely by inspection. Now, how do we further localize or confirm our diagnosis? The next step is to look for eye movements. If you remember, in examination of the eyes, I told you, one step is looking at the eye movements. So here I have given you the eye movements, which you already know. All the eye movements are by the third oculomotor nerve innervation, except superior oblique, which is by the cochlear nerve, and the lateral rectus, which
lateral
is by
rectus and superior oblique muscle.
Okay. So SO4, LR6. Right. So now we have a diagnosis of oculomotor nerve palsy. Is that good enough? Again, the answer is no. So why do we localize? Because the reason we localize is to answer the second question. Now, if we say oculomotor nerve palsy, there are so many causes, and we won't know which one it is. Like I told you, we started off with the picture, the cartoon of a detective. The cartoon of the detective is, right, Sherlock Holmes needs to get to the exact culprit. You can't give 10 people and say these 10 people have committed the crime. You have to know exactly who committed the crime. Who is the culprit? So that is why we localize. So if we don't localize further, we cannot know who the culprit is. So once you have diagnosed oculomotor nerve palsy, we need to go further into where the lesion can be by going through the anatomy and its related structures. Okay. So let's start from proximal. We start proximal. We know that the third cranial nerve starts where? Which part of the brain?
Superior colloquial.
Very good. Midbrain. So from the midbrain, it comes anteriorly to the base of the brain, cavernous sinus, superior orbital fissure. So the lesion can be anywhere in that pathway. Now if you take the midbrain, you know all the structures in the cross-section of the midbrain, and that is why you learn the cross-section of the midbrain. So that if you have a lesion there, you know in a midbrain lesion, if you have a third nerve, you will have a contralateral hemiparesis, because these are the pyramidal fibers here. So if you have a lesion here on the left side, you have a left-sided third nerve with a contralateral hemiparesis. So you know the patient is not going to say, I have a midbrain lesion, but the patient will come with a third nerve and a contralateral hemiparesis, which then you know is in the midbrain, because you have oculomotor neuron signs. It is after that that you can answer the second question, what is the lesion? So now that you know it's in the midbrain, your differential diagnosis is there. Stroke, tumor or demyelination that is specific to that site. Okay. Next, we come a little bit more anteriorly. Now the nerve emerges from the midbrain and then it passes through what? It passes through the circle of Willis. If you look carefully, you can see my cursor here. This is the third nerve that passes through the superior cerebral artery and the posterior cerebral artery. What you see there is the posterior cerebral artery, here is the superior cerebral artery. And as it passes anteriorly, it is parallel and very close to the posterior communicating artery. Okay, so that is the relationship. So you know any lesion in this region would have associated other features of the structures close by. Just like what we saw in the midbrain. If you have a lesion in the midbrain, you're going to get upper motor neuron signs, and because the pyramidal fibers were there, the corticospinal tract, you get contralateral hemiparesis, or what we call the Weber syndrome. Now here, if you have a lesion, then you are going to have associated other manifestation. That brings us to your second pole, which is a multiple choice, true, false, right? So there are several answers, not one. What are the ocular abnormalities? There are several correct answers. Select only the correct answers. Move the pole box away if it's obstructing your view. You have 30 seconds more. Fifteen seconds more. Ten seconds more. I've given you 1.5 minutes, not 1 minute. Multiple choice. Okay. So the answers are 91% dilated right pupil, 16% small left pupil, right medial rectus weakness, again majority, left medial rectus weakness, proptosis. Now this is a bit tricky question because you do not know which way the patient is looking. So you have to assume that he's looking forward. So if you are not told which way the patient is looking, always assume that the patient is looking straight. So if the patient is looking straight, then this side looks deviated to the right side. So if the eye is deviating to the right side, then there is right medial rectus weakness. So if this is the abnormal side, then this is the abnormal pupil. Otherwise you won't know whether this is small and this is large, or this is large and this is small. You won't know which is abnormal. So here, this is a deviated or paralyzed right medial rectus and a dilated pupil on this side. Now proptosis, again, some of you have marked proptosis as true. That is because you do not realize that proptosis you cannot diagnose by looking from front. For you to diagnose proptosis, you have to come from above the patient's head and look whether the eyeballs bulge with the eyes closed, whether the eyeballs bulge beyond the superior orbital ridges. Or you have to come from a side and see whether the eyeballs are bulging. So that is the definition of proptosis. So you cannot diagnose proptosis on a picture. Therefore, proptosis cannot be true. Okay. So the correct answers are a dilated pupil on the right side. Now, a dilated pupil is very important. Where I showed you the third nerve emerging from the midbrain, you see a dilated pupil. The commonest cause there is a posterior communicating artery aneurysm. Posterior communicating artery aneurysm. And that will compress on the third nerve, which is in very close proximity. And when it compresses on the third nerve, there is dilatation of the pupil. Now the question is, why does the pupil dilate when compressed? Right? So this is called a compressibility. And there is an anatomical explanation. Now if you look at the oculomotor nerve, the oculomotor nerve has and these are the parasympathetic nerve fibers. The parasympathetic fibers are the fibers that constrict the pupil. They are on the surface of the third nerve. Now the blood supply to the third nerve is through the vasa nerve, which goes through the mid of the third nerve. The difference is that the parasympathetic fibers get the blood supply through the vasa nerve, plus they have an additional blood supply. So if you have a medical third nerve, meaning anything that causes ischemia to the nerve and therefore a third nerve palsy, like the most commonly is diabetes mellitus, where you have a third nerve palsy, the parasympathetic fibers are spared because they have an additional blood supply. Therefore, the pupil is never dilated. Whereas if there's a compressive lesion as shown by this black arrow, if it compresses, it does not respect any blood supply from any direction. So it will occlude the peripheral blood supply plus the central blood supply. So the parasympathetic fibers also will become damaged or ischemic. And as a result, it would dilate the pupil. Now this is an important concept, life-saving concept, because the minute you see a dilated pupil with a third nerve, you must know it's a compressive lesion. And some of these compressive lesions are neurosurgical emergencies, such as a posterior communicating artery aneurysm. Because if you miss that, that will rupture and the patient will die. Okay. So the most important instrument that you take into the ward when you go for your clinicals is a pen torch. Never ever forget a pen torch. If you do not own one, please buy one. If you don't have a pen torch, then you should not be going to the wards, because that's a life-saving instrument. If you see a dilated pupil, you must be very alarmed, because it can be a neurosurgical emergency. Not all dilated pupils are emergencies, but if you see it, your first assumption is that it is a compressive lesion. And in this context that we are talking, a posterior communicating artery aneurysm compressing on the third nerve, because it is very close to that artery as the nerve comes up. Okay, so then we move forwards. Then we come to the cavernous sinus. Now again, that is why it's important to know your anatomy. You know, in the cavernous sinus, you have the oculomotor nerve there in the lateral wall. You also have the trochlear nerve, the fourth cranial. You have the ophthalmic division and the maxillary division of the trigeminal. And you have the abducens nerve. So you know that a lesion in the cavernous sinus that involves the third nerve will also involve the fourth and the sixth nerve. So you get a complete ophthalmoplegia, meaning all muscles are involved. You also get sensory loss over the ophthalmic division and the maxillary division of the face. The mandibular division is there. You also know that cavernous sinus communicates with the opposite cavernous sinus. So if there is a pathology that can spread to the other side, you will get bilateral cavernous sinus lesions. So once you localize here by the evidence that there are other nerve involvement, then you know the causes. That is when you can answer the second question. What is the lesion? Cavernous sinus thrombosis, corticocavernous fistula, or carotid arteriosus. Finally, we come to the superior orbital fissure. So on the same principle of what are the nerves that are in the superior orbital fissure, which you remember by your leftisonium, lacrimal, frontal branch, trochlear nerve, superior division of the oculomotor nerve, nasociliary nerve, inferior division of the oculomotor nerve, and the abducens nerve. So you look for involvement of these nerves. If you find them, you know the lesion, you localize into superior orbital fissure. And then your diagnosis, again, the causes are different. You are thinking of Tolosa-Hunt syndrome. You are thinking of a tumor there. You are thinking of a metastasis there. You are not thinking of a stroke then. Now, if you just say oculomotor nerve, you say one possibility is stroke. When the patient has all these other features to suggest that it is in the superior orbital fissure. So I hope you understand the importance of localizing the lesion. So unless you localize it carefully, you cannot answer the second question. And the only way for you to localize the lesion is your clinical skills, nothing else. No point in memorizing all this, writing it down on a piece of paper and memorizing. When the patient is given to you, you should have the skill of recognizing these clinical features, putting your knowledge together and asking yourself where exactly is the lesion in this part. So I have just taken the third cranial nerve to help to illustrate this. I'll do another couple of cranial nerves, but for rest of the nervous system, that is how you work it out. Whether it's a cranial nerve, whether it's a peripheral nerve, you have to first ask broadly which nerve is affected. Next, ask yourself, where exactly in the pathway is it affected? Once you have found where exactly the pathway is, that is when you find out what the lesion is. Okay, what abnormality do you see here?
Bilateral ptosis.
Okay, what else? Yeah, correct. Bilateral ptosis is correct.
The left eye is slightly deviated to the left side.
Bit difficult to say that because his eyes are now like slits because they are quite significantly closed. Any other abnormality that you notice in the picture? Inspection, the power of inspection.
Symmetrical complete ptosis.
That was it. That we all agree.
He's trying to open his eyelid using the frontalis muscle.
Excellent. Now you can see the frontalis overactivity there. Can you see that frontalis muscles contracting? Okay. What else do you see? What are the abnormal? Observation power. Come on.
Mouth open.
Yes, mouth is open. So if the mouth is open, what do you think? Which muscles are weak?
Weakness of the masseter, the temporalis.
Yeah, the facial muscles. So now what is the first differential diagnosis when you see a face like this?
Facial nerve palsy.
Say again.
Facial nerve palsy.
Facial nerve palsy. Bilateral ptosis. In facial nerve palsy, you can't close the eye. Eyes will be open.
Upper motor neuron facial nerve palsy.
Still, in facial nerve palsy, the problem is in closing the eyes, not opening the eyes, because it's orbicular is ocular. Here, the patient is attempting to open his eyes.
Bilateral oculomotor nerve palsy?
Yeah, bilateral oculomotor nerve palsy. Right? So where can the lesion be? Now I showed you the pathway. Where can you get this bilateral third nerve involved? Think and tell me.
At the level of midbrain?
At the level of the midbrain, good. Where else?
Bilateral involvement of the cavernous sinus.
Bilateral involvement of the cavernous sinus. Very good. You all are hot. Very good. Answers are correct. This. Two more.
Demyelinating disease.
No, I'm not asking pathology, no dear. I'm asking where in the pathway. Now we went through the third nerve pathway. We said, okay, it can be the midbrain, it can be the cavernous sinus, because you have to think of something that causes bilateral problems. The midbrain is central, so you can have the bilateral lesion. Cavernous sinus, I just told you, they communicate with each other. So if you have thrombosis on left, you get thrombosis on the right, and then you get bilateral.
Tumor at the pons like
Where can it be? Come on, two more.
interpeduncula fossa. Interpeduncula fossa lesion.
Interpeduncular. Bilateral involved.
Uncal herniation of the uncal herniation due to increase in cranial pressure.
That will cause only unilateral.
Myasthenia gravis.
Yeah, myasthenia gravis, neuromuscular junction. Myasthenia gravis and snake bite. We did that lecture. And finally, so we are working from proximal to distal. You start at the midbrain, you come forward. And you know the cavernous sinus can be bilateral. Then when you come to neuromuscular junction, you know the toxins and the antibodies in myasthenia gravis will not affect only one side, it will affect both sides. What else? What is the next side? When you come?
Myopathy.
Yeah, myopathy, muscle. Okay, so now you see how you localize it. Now, which one do you think this one is? Is it midbrain, cavernous sinus, neuromuscular junction, or myopathy? Sherlock Holmes will know this. If you're observant and you're clever enough to use your knowledge, you will tell me.
Cavernous sinus.
Oh,
Because there's involvement of the trigeminal motor nerves.
what you see the thing about cavernous sinus thrombosis is also you will get, because when the cavernous sinus thrombosis, you get severe papilledema, severe congestion of the eye, proptosis. Red, angry looking eyes trying to pop out of the eye sockets. So this is definitely not cavernous sinus thrombosis. That is why it is observant to see his mouth is also open. Right? So there is obviously weakness of all the muscles, facial muscles, the ocular muscles, everything. So the lesion has to be at the neuromuscular junction or muscle. It's either NMJ or muscle myopathy. In reality, what this patient had was snake bite. They are after snake bite. In men. Okay. The differential diagnosis is a medical student at a lecture. How do you differentiate this from a medical student at a lecture? Anyone?
When ask a question, the student will wake up.
Student will wake up. Oh my God, no. How do you differentiate the medical student at a lecture? Medical student at the lecture, eyes are half closed, mouth is open. That's the usual.
Drooling saliva.
Drooling saliva is a medical student. Yes, that is correct. But what I want you to say is this frontalis overactivity. In a medical student, there won't be frontalis overactivity because they will be sleeping with their eyes closed and mouth open. Whereas this man is trying to open his eyelids. There's a question in the chat asking why there is frontalis overactive. There is frontalis overactive. This man is trying to open his eyes, but even the frontalis muscles are weak. So he just can't elevate anything. So although he's making an attempt, he cannot because all the muscles are paralyzed. Okay. Okay, so then we move on. Examine motor cranial nerves. That's another instruction that we give at the final exam. So now don't come to the exam and ask us, what are the motor cranial nerves that you want us to examine? No, we won't tell you because you are supposed to know what the motor cranial nerves are, right? Okay, now we come to your next poll, which is again, I have to change the poll to single best answer. Right. So it's a single best answer. Wait till I play the video. Don't answer. Don't answer. Let me restart again. Someone answered. Ticket answer. Don't answer. I'm playing the video. Wait for the video. Don't answer. Watch the video, then answer. I'll play it again. Okay, now answer. 1 minute. It's a single best, so 1 minute is enough. Okay, 10 seconds more. Okay. %12% are right low motor. 59% left low motor. 12% again right upper motor. Left upper motor. Right oculomotor, no one is wrong. So what's the correct answer? Face is deviated to the right side. Okay. So the lesion is on the left side, obviously. If you look at the forehead wrinkling, there is no wrinkling on this side. Okay. Now someone was saying the previous one bilateral facial because the eyes can't close. Here the problem is eyes can't close. You can open the eyes, there's no issue. So the face is deviated to the right side, you can see the forehead wrinkle. The lesion is on the left side. Now the next question is this upper motor or lower motor? That's the localization. So the first question is which nerve? Seventh cranial nerve. Which side? Left side. You are lateralized. Next question to localize is it upper motor or lower motor? That is the next question. So how do you determine that? That is determined on whether the upper part of the face is involved. If the upper part of the face is involved, then it is lower motor neuron. If the upper part of the face is not involved, then it is upper motor neuron. Simple as that. So watch the video again. Now you see in this video, when he starts, he's trying to close his eye. This eye doesn't close. Okay. Now when he wrinkle in the forehead, you don't see any wrinkles on this side. Again, watch again. He's trying to close. The eyes is not closed. Right? Then when he wrinkles, you see this side wrinkling. No wrinkling on this side. So the upper part of the face is affected. So the correct answer is left lower motor neuron facial nerve pulse. Correct answer is B. Everything else is false. Okay. So good. So now what is the anatomical explanation for that? If you take the seventh nerve nucleus, it's divided into the upper half and the lower half. The upper half gets innervation from both sides of the brain, whereas the lower half gets innervation only from the opposite side. Okay. So if you have upper motor neuron lesion, say on that side, it will only affect it will definitely affect the lower half of the face, right? The upper half of the face will have partial innervation because it gets it from the same side also. So the upper part will be spared. So the problem is in the nucleus. Students come to the exam and say, the seventh nerve supplies both sides of the face. No, it doesn't. The seventh nerve supplies only one side of the face. The seventh nerve nucleus gets innervation from both sides. So, and that is the upper half of the nucleus. Because it's the upper half of the nucleus that gets innervation from both sides of the brain. Okay. But if you have a low motor neuron lesion, it doesn't respect whether you get the innervation from one side or both sides. It doesn't matter because the final common pathway is gone. So both the upper part and the lower part will be paralyzed. So in this patient, he had a left lower motor neuron facial nerve also. Okay. Is that good enough for you to know? Answer the next question. So what are the possibilities? Well, that's also not good enough. So that is why you learn so much anatomy. Because for you to know, now you have understood that the problem is in the lower motor neuron. So you're not thinking about anything above the pons. You're thinking about everything below the pons. So you know that the nerve comes through this foramen. And here, not the foramen, the seventh nerve comes here. There's the geniculate ganglion, gives the greater petrous nerve. Then it goes through the petrous temporal bone. In the petrous temporal bone, it gets the nerve to stapedius, the chorda tympani, and then it comes out of the stylomastoid foramen. And then through the parotid gland, it divides into its branches. So for each of this area, there are different causes. So in the pons, it can be a stroke or a demyelinating lesion. In the cerebellopontine angle, if the lesion is there, you get cerebellar signs also. So then you get seventh nerve plus cerebellar signs. You know the causes are acoustic neuroma, meningioma, metastasis. If the lesion is in the geniculate ganglion, you know that geniculate ganglion has the herpes zoster virus. And the virus will come to the nerve, to the auricule, and therefore in the nerve, in the ear, you will see vesicles, which is also known as the Ramsay-Hunt syndrome. The nerve can be in the facial canal in the petrous temporal. If there's inflammation, by far one of the commonest conditions is the Bell's palsy, middle ear infection like otitis media, or a local trauma after a road traffic accident. You can have a fracture going through the petrous temporal bone and the facial canal. As the nerve comes out, it can be in the stylomastoid foramen like a parotid tumor, parotid surgery. So if you know the sites, then you know the pathologies. Without localizing, you cannot diagnose the cause. What is the diagnosis here? Hello? Hello?
Bilateral facial nerve palsy.
Bilateral facial nerve palsy.
Bilateral facial nerve palsy. Evidence by?
It elicits Bell's phenomena. It elicits Bell's phenomena, like when trying to close the eyes, the eyes move upwards.
Yeah, the eyeballs are rolling up when you try to close your eyes. So that's called the Bell's phenomenon. So which side is it?
Bilateral, sir.
What else do you observe?
Mouth open, sir.
Okay, what else do you observe? So bilateral eye closure is impaired. What else?
He's trying to smile.
Yeah, the mouth is open. So this is bilateral lower motor neuron seventh nerve palsy. What are the causes?
CP angle tumor.
Bilateral. Now just You need to think. And you have bilateral CP. Very rare. But the common things, you must say the most common thing first. I have already taught you the most common form of bilateral low motor neuron surgery.
Otitis media.
Otitis media දෙපැත්තම එන්නේ. I have taught you already what is the bilateral cause of bilateral low motor neuron surgery.
Myasthenia gravis.
Myasthenia surgery වෙන්නේ නැහැ. That is neuromuscular junction.
Guillain-Barré syndrome.
Huh?
Guillain-Barré syndrome.
Yes, Guillain-Barré. By far the most common is Guillain-Barré syndrome, bilateral low motor neuron. What else? Bilateral ones are rare. What is the most common of unilateral low motor neuron?
Diabetes mellitus.
Commonest unilateral low motor neuron.
The CIDP? CIDP?
Commonest cause of unilateral, unilateral low motor neuron.
Otitis media.
Okay. Bell's palsy.
Yeah, Bell's palsy. So you can get a bilateral Bell's palsy. So Guillain-Barré syndrome, bilateral Bell's palsy, other two you won't know, so I will tell you. Sarcoidosis, which is a granular metastasis, and leprosy causes bilateral low motor neuron survival. It's a very rare situation. The situation you will see as doctors would be Guillain-Barré syndrome, that I guarantee. Others you may not see because they are extremely rare. But Guillain-Barré syndrome, you will definitely see bilateral low motor neuron survival. Okay, we come to the final part of the lecture. The lower cranial nerves. Who is this man? From which country and what is he? Anyone?
He's a Maori from New Zealand.
Very good. Why is he sticking his tongue out?
It's part of the haka. They stick the tongue out to frighten the opponent.
Haka. The haka is the war dance. Okay. So how many of you have seen a haka? So for those who haven't seen a haka, there is no point living if you haven't seen the haka. This is the New Zealand rugby team. Wait a minute. You need to. I need to give you sound. There's no point living if you haven't seen the haka. So this is the New Zealand rugby team who performs the war dance because they all have Maori blood in them. The New Zealanders are proud to have their indigenous blood within them. So before every game of rugby, they perform the haka. If you haven't seen this, there's no point in living. So,
We can't see. I think it's a white screen.
you seen on your white screen?
Yes, sir.
Let's try again. What is that? Tell me if you can't see. That's not funny. Can you see the screen now?
Yes.
Yeah.
Can you see?
Yes.
Can you see now?
Yes, sir.
Yes,
You
sir.
can see now.
This is a war down. This bird is not. And see them sticking their tongue out.
The challenge has been made.
Okay, so that brings us to our next poll, the final poll. Right, there is a video, so don't answer the poll until you see the video. And whilst you're answering, I will be replaying the video. It's a single test, so you have 1 minute. Okay, you have 30 seconds more. Fifteen seconds more. 10 seconds more. 5, 4, 3, 2, 1, the end. Okay, so what is the diagnosis?
Right-sided low motor neuron hypoglycemic malfunction.
3 people who thought it was left, and left low motor neuron hypertrophy. Some about 30% thought it was left low motor. Right, so what you see here is when the tongue is stuck out, it deviates to the right side. And you see wasting here. So when you see wasting, you know the problem, there's a low motor neuron problem on the right side. So you already have the side. And it deviates to the right side. Right? Only the face and the palate will deviate to the stronger side. Everything else is deviate to the weak side. So if the tongue deviates to the right side, you know the lesion is on the right side. Okay, so remember that the face and the palate goes to the stronger side. The federal party votes with the stronger side, face and palate. Everything else deviates to the weak side. So because the tongue deviates to the right side, you can't, some 30% got it wrong saying left knee, so you can't get the left wrong. You say right. You know there's wasting, so you say low motor. So when you have low motor neuron lesion, patients present with dysphagia and dysarthria. Dysphagia is difficulty swallowing, dysarthria is slurred speech. Now, I told you bulbar muscles are muscles that are innervated by the cranial nerve that arise from the medulla oblongata. So in a bulbar palsy, we look for low motor neuron lesion when you talk bulbar. So it's low motor neuron, it will be a flaccid tongue, tongue wasting and tongue fasciculation. Now sometimes patients present with the typical bulbar palsy, dysphagia and dysarthria. But the lesion is actually above the medulla. Then, but the signs you get are different. Although the patient has dysphagia and dysarthria, the signs are upper motor neuron. There's a spastic tongue, brisk jaw jerk, and emotional lability, as we saw in motor neuron disease. So that is called, because it's like bulbar but not bulbar, it's called pseudo-bulbar palsy. So they are completely different, but the presentation is identical. Okay. So clinically we differentiate them. And what are the causes?
So how would we identify spastic tongue?
Spastic tongue is a tongue that cannot stick out. In a flaccid tongue, the tongue is easily put out and moved from side to side. In a spastic tongue, the patient can hardly stick the tongue out. And when you ask the patient to move the tongue side to side, it goes very slow motion. Flaccid tongue moves actually faster than spastic tongue. Okay. Now, when you try to figure out the causes or the sites, it's always good to start either proximal to distal. That means starting from the central nervous system to the periphery or periphery to the central. So if you start from periphery to the central, it can be the muscle, myopathy or myositis. Then you have the neuromuscular junction. Myasthenia gravis causes bulboprosis. The peripheral nerve, Guillain-Barré syndrome might cause bulboprosis. What is NPC? Nasopharyngeal carcinoma, which infiltrate the lower cranial nerves. Basal meningitis, like carcinomatosis, tuberculosis, granulomatosis can infiltrate the nerves. Then as you come proximal, the most proximal would be the central nervous system, which is the medulla. Like a stroke, most common, lateral medullary syndrome, Pica syndrome, posterior inferior cerebellar artery syndrome. Or motor neuron disease, we did a whole lecture on that, saying that the patient presents with dysarthria. I showed you a video of a 65-year-old man. You heard him speak and having severe spastic dysarthria. Okay, trying to describe his family. Then if you have pseudobulbar palsy, it has to be bilateral. Unilateral lesions won't cause pseudobulbar palsy. So it has to be bilateral lesion above the medulla. So bilateral strokes, motor neuron disease, and multiple sclerosis, because these are bilateral lesions that affect on both sides. So in summary, cranial nerve lesions are localized in relation to the neuroanatomical pores and their related structures. So that is what I showed you in time. So that you have to know the anatomy in order for you to localize. And the localization is done clinically, not on a piece of paper, question paper, answer script. It is done in front of a patient. Right? So the relationship with other structures are the ones that helps you to localize the lesion. And you always need to answer the first question in order to answer the second question. And throughout this lecture, I showed you the power of inspection, which I would say intelligent inspection is called observation. Right? In clinical diagnosis. So don't jump onto patients when you're given a patient or you see a patient. Always take a step back, spend a few seconds or a minute looking at the patient and, meditating on that, knowing what is going on here. Right? So that is called intelligent inspection. Who is this gentleman here? Yes?
Sir Arthur Conan Doyle.
Yeah, Sir Arthur Conan Doyle, who is the author of Sherlock Holmes. So what was his inspiration? Who did he model Sherlock Holmes on? Anyone?
One of his professors at the medical school.
Yeah, so Arthur Conan Doyle, when he was a medical student in Edinburgh, one of the doctors, one of his teachers, who was Sir Charles, not Sir, he wasn't Sir, he was Dr. Charles Joseph.
Bell.
Charles Joseph, not Charles Bell, Charles Joseph, who was a surgeon who, when patients come, would take every clue and tell the story before the patient actually volunteers. And then he noted that everything the surgeon said was correct. Where the patient came from, what her background was, how many children she had. Even without asking the patient, this surgeon would look at this patient and through observation would make all those predictions, which were correct. So that is what inspired Arthur Conan Doyle to write Sherlock Holmes. Right? So this is his famous saying, which is also relevant to you. You see, but you do not observe. So inspection is intelligent. Inspection is observation. So if you observe, you see a lot. So that is all for clinical neurology. And that's the end of lecture. Before we go on to the next lecture, we'll take a small break for you. So now the time is 2:31. You join in at 2:40. Don't go off. Don't go off. This is the same link we are going to use. You can switch off your videos and you can go away. Come back at 2:40. Don't log off.